Good afternoon. I'm Bruce Gelb. I'm the director of the Mindich Child Health and Development Institute that's sponsoring this webinar today, along with the Department of Pediatrics. The title for today's webinar is Children and COVID-19, What You Should Know. And our goal, of course, is to talk about what's been happening these last 6 months or so, what we've learned and what still lies ahead and what we're still trying to figure out and what can be done safely with our kids today. So we hope it'll be most interesting and exciting. You will note that the Q&A function is on for this Zoom. We don't know, honestly, if we're gonna have time for outside questions as we get to the end. So you might wanna hold off in typing those in yet. As we get closer, if it looks like there'll be time, I'll give you a heads up and find time. Otherwise, you can certainly contact us at another time. We're happy to answer questions. So with that, we have 3 panelists who are joining us this afternoon, and I'll introduce them one by one as we get to the first questions as we go around. So I'm going to start with George Ofori-Amanfo. George is the chief of the Division of Pediatric Critical Care. In other words, he's in charge of our intensive care unit. And that's obviously been center clinically of the care for kids who have come to Kravis Children's Hospital when sick with this. So George, let me start with the following question for you. Tell us, as somebody who's really on the front lines, what you've been dealing with in your ICU, both in terms of the early phase when we were seeing kids infected and then how they were presenting later. And maybe tell us a little bit about like how old the kids were and whether they had underlying medical conditions or not.
Sure, thank you, Bruce. Thank you all for being here with us. It's a really good opportunity to share experience with you from Mount Sinai. As a pediatric intensivist, actually my first experience with COVID was being part of an adult team taking care of adult patients. So we had the privilege of, or the pleasure of seeing this disease in a different patient population. And this was just before we started seeing pediatric cases. And the cases in children, actually, we saw in 2 different phases. The first wave of illness was patients who presented with symptoms very similar to what the adults presented with, which is mostly fever, cough, runny nose, some difficulty in breathing, and some of the patients actually had low oxygen in their blood and required oxygen support. Whilst these kids presented very quite sick, they were not as sick as the adult patients. And we had learned about this presentation in children also from the China experience and everything we had read about, that children were not so sick from the disease. We did admit them to the intensive care unit, mostly to be prepared for any decline in clinical condition. They all did very well. Some of them required some oxygen support, but they did well and went home. The age kind of ranged between 1 and 14 years of age. Most of them, when they presented, the x-rays had a little bit of congestion. Some of them had some signs of pneumonia in the lungs on the chest x-ray. But with oxygen treatment and supportive treatment in the hospital, they did very well and went home. And I had to mention that in this first wave of the illness, the patients that presented, majority of them had underlying medical conditions. Some of them had, the majority of the patients who had underlying conditions had asthma. A few patients were being treated for cancer, and some of them also had diabetes and heart disease and other illnesses. But again, they all did very well and had short length of stay in the hospital and went home. And as we all worked as a community in the New York area, we all worked so hard to flatten the curve. The number of the cases presenting like this kind of tapered off. And then about a month or so after the peak of the disease in New York, we saw this new wave of the disease, which has been called the multi-system inflammatory syndrome in children. This presentation of COVID actually was a very serious illness. Being so serious, fortunately, there weren't as many patients that we saw, but the patients presented often coming in with fever that's been of a few days duration, mostly between 4 to 7 days duration, abdominal pain, which got progressively worse to the extent that some of the patients actually could not eat or keep anything down. They were vomiting. Some of them had diarrhea, some had chest pain, And when they came in, usually shortly upon presentation, they have such profound drop in their blood pressures that they would require acute resuscitation in the emergency department in the intensive care unit. So we took care of these patients, mostly looking at what the disease is. And so our initial investigations show that this disease was actually a profound inflammation to COVID exposure. And the blood tests the tests suggest that they have some response, antibody response to COVID, but they do not have evidence of active or current COVID infection. And so the way we put it together was that these children may have had exposure or a mild infection to COVID a few weeks preceding the acute illness, and having an abnormal inflammation or inflammatory response to the COVID. And so being inflammation in the blood, all or any organs could be targeted. And so their presentation pretty much depended on which organs have been involved in the infection process, are targeted in the infection process. And so some of the patients will have headache and dizziness if the brain is involved. They will have involvement of the blood, and in that case, they'll have clotting problems of the blood. And some of the patients will have severe abdominal pain if their gastrointestinal system are involved. And we see a variety of presentations. And then the ones who actually need the ICU care are the ones who have the profound hypotension. And these patients sometimes got so sick that they require a lot of fluid resuscitation through giving fluids in the vein. They may also need blood pressure medications to maintain their blood pressures. And in a few patients, all these measures actually could not get their blood pressures to a healthy level, so that they would require artificial support of the heart to maintain their blood pressures. So this is what we saw, and actually was quite profound. And this jumped out at us, knowing very little about the disease. And so as soon as we started seeing them, we collaborated with, we set up a team within Mount Sinai, knowing that this is a multi-system disease. It requires specialists in different areas to take care of the patients. And so here at Mount Sinai, what we did was, first thing is got all the experts together to a round table to discuss how to approach this illness. So we very quickly came up with a way to investigate the patients, a way to treat the patients, standardize the care we provided. And also, because we did not know much about the disease, we involved our research scientists also to be involved with us to help us investigate the disease, understand it, and help us design ways of treating the disease going forward.
We were warned not to do it, and there I went. Charles, let me ask you one quick follow-up before we move on. You know, we heard a lot in the adults about care of the adults, how they learn things along the way, and by the end, we're doing it differently than they were in the beginning, stuff about lying them on their stomach and so on. Is there something comparable with the kids? Are you doing it differently, as we say, think to the fall when the first kids, if we're getting more kids showing up, that the way you'll treat them versus what we were doing at the beginning?
Absolutely, that is so true. When the kids started coming, again, we had no idea the clinical pathway for these patients. We did not understand how they were going to progress. And so initially, we did a whole broad spectrum of investigations, and essentially threw everything possible at the patients, make sure that we got things right. But going forward, as we learned case by case, we realized that, all right, we could target the immune system specifically. And so we learned with modalities to target the immune system. We learned about ways to protect the other organs from being affected. And then we also realized that, you know, blood clotting seemed to be a universal problem amongst the patients. And so we also learned very quickly that all these patients need to be aggressively treated with blood thinners to prevent any further organ damage. And so we did learn along the way. And the way we learned is, again, involving our multidisciplinary team and discussing every single patient about what we've learned about this patient, how does it add to what we've learned before on previous patients, and use that information to help treat the next patient. And so over the next few patients, we had a standardized approach of treating the patients, and we got more comfortable. We had a way to do it, and we think that going forward, we also probably had improved outcome from patient to patient because we learn from each patient.
Great, perfect. Thanks so much. Next, let me introduce Dr. Karen Wilson. Karen wears several hats at Mount Sinai for the Department of Pediatrics. She's the Vice Chair for Clinical and Translational Research. She's the Division Chief for General Pediatrics, so oversees a lot of the outpatient care of kids. And she both developed and still oversees our hospitalist group. Those are the physicians that are taking care of a lot of the kids who are in the hospital, but not in our ICUs. So Karen, along similar lines, your group both saw the kids when they did come out of ICU, and you also took care of the kids, some of them who came in sick, either acutely with the novel coronavirus or with the MIS-C disease that George mentioned, if they weren't sick enough for the ICU. So talk about what it looked like for your team in terms of caring for these patients.
Yeah, so this was very interesting. Thank you so much, Bruce, and thank you all of you for joining us today. Your support is so incredibly important, especially during this difficult time. It was very challenging. Initially we didn't have that many patients. As George mentioned, most of the kids who were in initially with COVID, we had many of them on the floor. Some of them were just kids who had other diseases like appendicitis or had a fever as a newborn, and they just happened to be COVID positive. So those weren't really that sick, and it wasn't really quite as challenging for us. Although many of our faculty, all of the faculty actually, except for myself, ended up attending on COVID units on the adult side. So that was a big thing for us to be able to provide those services for the adults. What we did see was that once the patients with MIS-C started coming in, this was such a challenge because, as George mentioned, this was a new entity. We really had no idea how we would go about treating these children. We didn't know what their outcomes were going to be. We didn't know if we sent them home, what would happen. Would they be okay, or would they get sicker? And so we really had to work as a team and come up with the guidelines, as George had mentioned, to be able to think about, how do we treat them in the hospital? How do we treat them in the ICU, on the floors? And then how do we send them home, and what type of follow-up would they need? It was very interesting to see the difference. When that first set of patients who came in who had primary COVID, who were PCR positive, many of them had, as George mentioned, many of them were immunocompromised. They might have been on chemotherapy. They might have had other illnesses. The children who came in with the multisystem inflammatory syndrome, really for the most part, quite healthy when they came in. And I think one of the really exciting things about this, obviously this has been a huge challenge and really horrible for the families that have been impacted, but we as a community have come together in pediatrics and really worked to collect data, to understand what is happening with these children, both the primary COVID and the MIS-C. I believe that we now have at least 5 papers that have been published already, and another probably 3 to 5 that are in the process that will really help to advance the knowledge of COVID-19 in children. And that's due to just the remarkable efforts of the folks in pediatrics and in Mindich and other areas around the institution.
So Karen, a follow-up, if I might, sort of getting at that. At the beginning, the mantra was kids are fine if they get this. What are pediatricians doing differently now that we know that at least a very small percentage of the kids may get really quite sick in the way that you and George have described? What are they doing on the outside?
Yeah, this has been a huge challenge for us. Is figuring out how to adjust our particular outpatient pediatric practices. And our group has come together and developed guidelines for a protocol for when you are seeing a patient in the office, at what point should you go ahead and get additional lab studies. One of the things about the multisystem inflammatory syndrome is that there are pretty typical lab values that we find with that. So if we have a child who's had a fever for 3 or more days and has any of the other symptoms like a rash or abdominal pain or vomiting, then we can send them, if their blood pressures are okay, we can send them for labs that will really help to either confirm or say that this is probably not the multisystem inflammatory syndrome. So that's been very helpful for our outpatient practices to be able to have some guidance about how to address this. And certainly we didn't expect this when we first started seeing COVID patients. The multisystem inflammatory syndrome came out of nowhere. I do want to I do want to highlight that it's still, as Bruce mentioned, very, very rare. So I believe that we are now, we've now seen maybe at 250 cases in New York State, and we've had, I believe now over 500,000 positive COVID tests. So the number of children who are impacted by this is extraordinarily small, and and for the most, almost all of the children have done very well, and we followed them up afterwards, and they're recovering. All of their lab values are going back to normal. They sometimes had cardiac involvement, and that has for the most part all gone back to normal. So that's a good part. But these kids were also very sick, and so when we're thinking about the risk to children, you have to weigh the fact that this is a very unlikely thing to have happen, but it was a pretty serious thing. So it has made things more challenging.
Thanks. I'll just add one line to that maybe. If people are doing the math, it's a lot less than 1 in 2,000 probably, because people will know there were many more people infected than were tested. And in kids, that's even more so, because especially for the first couple of months, we weren't really testing children much at all because we understood they weren't getting acutely ill. So let me turn to our third panelist, Dr. Dusan Bogunovic, who is an immunologist, particularly with training in immunogenetics. He studies genetic disorders that affect the immune system, most of which present in childhood with various forms of illness related to the immune system, often related to infections. Because of that work, recently he was named the director of a new center, a center that the Mindich Institute, along with Mount Sinai's Precision Immunology Institute, is creating to study inborn errors of the immune system. So Dusan, we heard George mention that we came together to start studying kids to try and understand these disorders, and Karen alluded to some research going on, some papers published. So you've been overseeing sort of the more basic science part to understand the immune system. Maybe you could share with us a bit of what we've learned so far about MISC in particular, I guess.
All right, so hello everyone. Thank you for the nice introduction, and thanks to everyone for joining us. Yes, it's been absolutely extraordinary at Sinai, the amount of effort that has been put in and resources to really understand MIS-C, or multi-inflammatory disorder that happens in children that we just spoke about, at every aspect, from those clinical management, what's happening afterwards, to the very basic science. So far, what we know is that it happens about 4 to 5 weeks after the initial infection with SARS-CoV-2. We know that it is extraordinarily rare, as Karen has pointed out, very, very rare in a syndrome. It reminds us of a different syndrome, which we call Kawasaki disease, which also happens following an infection with a virus, and it's also exceedingly rare. We don't know at this point, but if it follows the pattern of Kawasaki, it usually does not recur, which is also, I think, fairly good news. It's, as George and Karen have mentioned, there's a lot of inflammation going on. We are measuring that in the blood. We are studying the blood cells to measure that, and we're also measuring the antibody response both to the virus, but also whether our own immune system, we think, might be attacking self. So those are all hypotheses right now that we are exploring and doing very in-depth research to better understand how this disease truly manifests.
Great, thanks. George, let me come back to you. So we have a lot of parents online. That's mostly, I imagine, who's with us. Everybody's worried about this, particularly as we move to the fall. So somebody has a child, the child has fever. What should they do? How do they know if they need to seek help? Should they automatically get tested for COVID? That sort of thing.
Well, that's a very good question. And this question always comes up, and also being a parent, I ask myself the question too. So the symptoms of COVID, as we mentioned, they fall into these two categories. So the early clinical picture we saw, which is the cold symptoms, cough, runny nose, congestion, decreased oxygen level in the blood. Those are, one set of symptoms that, patients could present with. And so as a parent, I think what to look for in your child, if your child has fever that's lasting more than a day, your child has cough, runny nose, congestion, and having difficulty breathing, I think these are early signs that, as a parent, we should call the pediatrician. Now, the other thing to worry about is the child has fever and is developing this abdominal pain that's getting progressively worse, vomiting, diarrhea, muscle pain, and sometimes dizziness. These are worrisome symptoms that could suggest the MIS-C syndrome that we're referring to. And as Dusan mentioned, the MIS-C syndrome also can have symptoms and signs that suggest the Kawasaki-like illness that we know of. And these typically present with rash and redness of the tongue, redness of the eyes, and sometimes swelling of the glands in the neck. And this is also another aspect of the presentation of the MIS-C syndrome that we would see or potentially see in children. And so when your child has these kind of constellation of symptoms, then I think definitely give a call to the pediatrician. If, on the other hand, you feel like your child is sicker from these symptoms or is having dizziness, confusion, and more sleepy than usual, then that would require one seeking urgent help, which means going to the emergency department or calling 911. And so through our collaboration with our physicians within the hospital, our outpatient physicians, we have been able to raise awareness, and we have a set of our planned guidelines that we institute straight from the office, from the ED, or when the patients come into the hospital. So we have a continuum of care that we've established with our outpatient physicians. And so a call to the pediatricians will trigger the guidelines, and the appropriate investigations will be done, and any early warning signs or anything suggestive of this MIS-C or COVID illness, the patient will be referred for the appropriate care.
Thanks, George. Karen, let me come back to you with what I think is, I can say, the hottest topic right now. Of course, we're towards the end of August and everybody is concerned about school. What are the criteria? Should kids go back? What is safe to do? So I'm sure you've been hearing the conversation. I don't have to say more. Tell us where your thoughts are and others in the pediatrician community.
Yeah, so this is such an important question, and I've seen in the chat and in the Q&A that this is coming up, not only for school but also for childcare, and how do you do play dates in the era of COVID? And I have to start by saying that we really, in a lot of ways, we really don't know. We haven't been able to closely study this yet, and so I think all of us are trying to take the evidence that we do have and synthesize that into something that makes the most sense. And there's even disagreement among pediatricians about, whether we should just get everybody back into school. I mean, there's a group of pediatricians who really wants everyone to go back because they believe, and I think this is true, that, that for most children, being in school is the best place to be, particularly for our underserved communities. Online school is very challenging, and the school may be their main access to food, healthcare, and any technology. But we also know that schools have to be safe, and we need to figure out how to make that happen. I think it's been pretty clear from the research that's come out so far that there are, I think, 4 major things that that need to happen. So masking everybody, children and teachers, or people in general, I think is really critical. That has definitely been shown as something that can prevent the spread of the coronavirus. Making sure that there's good ventilation in the classrooms or in the places where kids are having their activities. Maintaining distance between teachers and students and other people, can go a long way to helping mitigate the risk. And then sanitizing procedures. So you have, you want to make sure that things are getting, that there's a very clear protocol at a school for sanitizing. So reducing the density, I know, is being done in a lot of schools. Sanitizing is really important. Testing, so testing children and teachers to make sure that you're catching things. There is a recommendation from a scientist at MIT that we should have the rapid antigen test And it'll be interesting, Dr. Bogunovic, Dusan may be able to comment on this, but if we can test every couple of days, then we can really catch any exposures that are, any kids that are getting sick or teachers that are getting sick before they have a chance to expose other kids. Finally, having the ability to create pods and create like smaller groups of learners that all work together, or children. So I know some families are creating pods for at-home learning, where they're going to get together with a couple of other families, and those children will all learn together in one place, but not in the school. And that way you can have the risk of exposure is less because you're controlling the number of people that you're exposed to. And I think that also is something that can be very helpful. So we'll have to see as the fall goes. We'll have to look and see, the people that took the pod-based approach, the people that are sending their kids back to school, and we've seen this not go well in Georgia. When you go back to school and you're not masking and you're not, and you're not really socially distancing. It is definitely related to a new outbreak there. And so I think that model clearly is not working. And so I think we need to think about this carefully when we're looking at the schools. I do want to say that it has to be a school system decision, but it also has to be a family decision. And each family is going to have their own requirements. They're going to have their own resources. They're going to have their own stresses. And, even within a family, there may be one child who is very happy with at-home instruction and working on the computer, and one who really, really needs that, the ability to go to a school every day and interact with other people. And so you might have one family that actually has two children in different places. So it comes down to an individual decision, along with thinking about the other factors in the lives of your family.
Thanks, Karen. Karen, just very quickly, relatedly, what should families do? Let's say grandparents are living at home or nearby and being seen often, or there's a baby in the house. What are thoughts about how to handle that?
Yeah, those are very difficult decisions. I'm a little bit less worried about the baby in the house. As you've heard, the risk of COVID is very low to small children, and the risk of the multi-system inflammatory syndrome, we saw very few young children with that. It was mostly older children. It's not zero. So that is going to be something that every family has to judge. I would be more concerned about having an at-risk adult. Or a grandparent who's in the home. And I think that those families should really think carefully about how they would be able to protect their family member if they were, if the child does go back to school. And I would want to make sure that those children were being tested pretty regularly, and also probably wearing masks and socially distancing in the home. I think for anybody who is at risk, as the rate, if the rate starts to creep up in the population in particular, I think you have to be quite careful about that.
Great, thanks, Karen. Let's go back to you, Dusan. Tell us, built into what Karen was talking about is the question of whether or not kids can pass it to each other. What do we know? Is it age dependent? What do we know about contacts, both through the air, from surfaces, and so on?
Right. So children can pass it to each other, and children can pass it to adults. As we've learned, they're usually asymptomatic, so that is good for the children, and means that they are very low risk of developing severe disease, even though it can happen. So it can, a virus can live on the surfaces, which goes to Karen's point of sanitation. And the surfaces now that we've studied can last anywhere from 2-3 hours to 2-3 days, which means that, at the very least daily, if not more often, cleaning of surfaces where there is a lot of individuals who are coming in and out is very good practice. In deciding whether children go to school, I have to second everything that Karen has said. It's really a public epidemiology question, but it's also a personal question. I have 2 children, and I am sending both of them to school. And why I made that decision is because we are not contacting with grandparents. It's an easy decision to make for me because the grandparents on both ends live in Europe. So there is, it was just decided for us. If they lived in our proximity, we would probably maintain social distancing and wear masks around them should we send them to school. So wash hands, wear masks, and socially distance. The less interaction, the better, but mental health for children and adults is equally important. And outweighing risks of potentially being ill with SARS-CoV-2 in children versus their social interaction. I am more in favor of social interaction, provided they are not the ones that are going to disseminate virus to somebody who is susceptible, meaning usually older adults. So I'll stop here for now.
Yeah. I just want, if I can take the MC prerogative here, I just want to add a couple things to fill in a couple details. I don't know if it's helpful, but I hope so. One is to pick up on Karen's point. I think, we're hearing a lot of news. In the next month, I guess, we're going to hear about like every kid in every school system who winds up having COVID or a school that shuts down. And we do need to know about those, but let's make sure to keep it in perspective. Georgia never should have opened their schools. Their testing rate was at like 30% when they decided to do this. Most experts would say you have to be down under 5%. New York is under 5%. It's one parameter. There are others. That's one example. The second thing is, remember that the goal here is not to get, ideally we'd like to have nobody get infected, but actually when we get to that, that means the whole pandemic is over. The goal here is to have very few people get infected. So just because we hear of one child in New York, let's say, who gets it, that will not mean the system is failing. So I think we have to put in that perspective. And one last thing to mention is that Dusan alluded to Europe, and I would just suggest that if you can, keep a little bit of an eye on other places. There are other countries that are ahead of us in terms of thinking about and sending their kids back to school. A number of countries in Europe, including ones that got hit pretty hard, including as hard as New York did, managed, once they got the thing under control, to reopen the schools. They did it in different ways. Some did distancing, some did masks. Some said little kids don't transmit much by the air, so we're not going to worry about that. Some did, clustering, some not. And for the most part, actually, the experience has been very positive there. But the truth is, we're still learning. We're going to learn here in the US, but do keep an eye on it. Those places are also informative for us as we go on. Dusan, let me come back to you for one more question before I move back to George. You alluded to testing, and it's a little confusing. There's obviously the PCR test, but then there are different antibody tests. There's fast ones, ones that seem to take days. What do we know about how well various things work, especially the rapid tests?
Okay, so it's a big question, and it's a question that's developing. So let's split this into two parts. One is, let's talk about antibody testing first, which for now does mean that you are immune to SARS-CoV-2, and most likely you will not get reinfected. That test is a blood test, and there's no other way to test for antibodies but to get a blood test. And if you have test that's positive for SARS-CoV-2 antibodies, that means that you have been infected in the past, whether or not you had symptoms. So far, the study suggests, and we have only 4 or 5 months of data, is that these antibodies are protective 4 or 5 months after this initial infection. So there is no reason for now to think that this, how we call immune response, is going to go away and we can get sick again, right? We have to monitor that, and that'll take time. Nobody likes giving blood, especially not children, right? So that's difficult, but it is one and done, as close as one and done can be if you are positive at this point. Second part is whether or not we can detect virus that we currently are carrying should have been infected fairly recently. Standard of care right now, if you come, and by the way, Sinai has developed one of the first FDA-approved serological tests, meaning the antibody test, and they're on the market and they're doing very well. And I am, proud that Sinai has been able to act that fast, and has deployed it around the country. Also at Sinai, you can get tested by PCR to see whether you have a positive virus. Usually that means swab from the nose, and it's decent, it doesn't hurt, but it's very uncomfortable, and also children don't like it. So far on the market, FDA approved are 3 tests that are prescription only, that are saliva tests. So you chew, or the kid would chew on something, spit in a tube, and then it would the same PCR test would be ran, and it appears to be decent. It's not rapid. It takes at least a day, just like it does for the swab to be done, but that's the least invasive one, and only physicians can order it. I'm not sure in how big demand it is or what's the turnover there, but they do exist. I also know in development, right now I haven't seen them, but I was on a call yesterday with a company that is working with Sinai trying to implement this type of test, and that would be the rapid colorimetric test that takes about 20 minutes to do. They're not commercially available. They're not available at all at this point or approved, but they are going to be coming, and I think I hope very soon, but those things you don't know because you have to pass certain levels of specificity and sensitivity of the test that FDA requires. And at that point, I think it'll be much easier to routinely test everyone before you go and have dinner at grandma's.
Great, thanks. George, let me go to this. Do we have, we were talking about this a little bit, do we have any idea overall, maybe in New York, how many kids have had this? How many kids have gotten sick and not pleasant to think about, but what's the rate of losing kids when they get infected, if we know?
Yes, so as Karen mentioned, the straight COVID infections like the adult disease, the respiratory infection, we did not have any non-survivors from that. And I think based on the New York numbers, only about 1% or so of the patients, so 1 in 100 of COVID cases, were actually 1 in 1,000 of COVID cases were pediatric cases. And so that's very small number compared to what the adults experienced. And then when you look at the MISC, New York State has about 240, 245 cases reported so far. And of all of these, we lost 2 of the patients, 2 non-survivors. And so again, it's a very rare illness. When you look at the total number of COVID cases in New York and only 250 or so had MISC, that's a very small number. And of the 250, we had only 2 non-survivors. And the 2 non-survivors are also patients that we saw very early on when we started seeing these cases before we got so much better at taking care of the patients. And so to put it in perspective, as you mentioned, Bruce, it's very, very rare, and the risk of mortality, the risk of death is also very small.
And George, you alluded to asthma before. I saw one question come by. I'm sure a lot of people online may have kids who actively have asthma, or at least had asthma when they're younger. What do we understand right now about what that does in terms of risk?
Well, what we do know is that just like we see in other respiratory illnesses, patients who have a history of asthma, when you have another illness that affects the lungs, they tend to be a little sicker, and their illness tends to last longer. And so I think the straight up COVID, which affects the lungs, patients who have a history of asthma may end up being maybe a little sicker from it. But when it comes to MISC, which is not a primarily disease of the lung, the patients did not have any underlying illnesses. They were previously healthy patients in whom asthma and other underlying illnesses actually did not play a role at all in their presentation.
Thank you. Karen, we talked about school kids. Could you talk about kids who are in nursery school, pre-K? How do you balance their development and what they gain from being around other kids versus the health risks?
They're an even more challenging population, I think, in terms of getting kids together, because, even though we recommend masking for children 2 and over, it's pretty hard to keep a mask on some 3 and 4-year-olds. And, and certainly social distancing is not something that they really understand well. So I think this, again, comes down to the family situation. There are plenty of families across the United States that that have a mother who stays at home with children up until kindergarten. And these children do absolutely fine. They're, I don't think if you have an enriched family environment, if you have a parent who is able to spend time with the child every day in engaging activities, or somebody or another caregiver who's able to spend time with the child in engaging activities, particularly if there are other children in the household, I think that is a very enriched environment. The struggle would come with, families where both parents are working from home and are on Zoom calls 12 hours a day and can't really pay attention to a 3-year-old, and a 3-year-old is not going to understand that. And I think those families will have to think very carefully about how that child can receive the interaction that they need, and that might include the risk, having the risk of going to nursery school at that point. Obviously, the same things apply to nursery school as the older kids, figuring out how to keep kids apart, figuring out how to clean everything well, figuring out how to get them to wear masks will be very important. But I think it's also very important for families that are that are unemployed, or where you don't have a lot of enrichment for the child, that I think nursery school becomes a more important and probably more worth the risk.
Second. There we go. So built into that is the fact that, in fact, this has been an unequal epidemic, right? That the families who are less well socioeconomically, and particularly people of color, have been disproportionately affected in New York. And then in terms of some of these social issues you're talking about, they're also at risk. So, you lead our program for underserved children. Could you speak to the challenges for these vulnerable children and families?
Absolutely. We know that this has been a big challenge, as I mentioned before, for most vulnerable families, both because of the outside risk of actually contracting COVID, and we do see the multi-system inflammatory syndrome seems to be more common in people of color and children from underserved backgrounds, but also they are more at risk from the negative social effects of social distancing and being quarantined and staying at home. Many of these children don't have access to good internet. They don't have access to a laptop, and so they can't really continue their schooling. So I think that it really has had an outsized effect. We were able, with support from the Children's Center Foundation Board, to create a phone survey of families in our outpatient pediatric practices. So we are looking at the impact of the social distancing on family life, including things like food insecurity and ability to access healthcare, those types of things, those social determinants of health. We are still analyzing that data. We just finished collecting it, but it's clear that COVID has had an outsized effect on our most vulnerable children.
And Karen, I'm going to come back to you one more time. I know it's not on your list, but let me ask you this. I saw this question come by, and I think it's a good one. And I know you're thinking about studying this. What do we understand for children about the longer term effects of having been infected? There are reports of kids who are still having some problems in terms of thinking or tiredness down the line. And how are we going to get at understanding long term, whether there are effects 5-10 years later? Who knows?
And that's incredibly important. So there's a couple of places where that's happening. So on an individual level, we are definitely following up the children that we have been, that we cared for here at Kravis to see how they're impacted over time. And Dr. Rebecca Trachtman has been amazing in partnership with this. She's our rheumatologist, and for the inflammatory system kids was the primary person who followed up with them, along with hematology and cardiology. And so we will be looking over time to see what those longer term effects are. As I said, most of the children are, particularly with MIS-C, are getting better. And I do think that there are primary cases of primary COVID where even for older adolescents and younger adults, there are lingering and long-term effects, and we will definitely need to continue to monitor that. So in addition, we are partnering with some larger organizations to think about being a center that is part of a larger national study on the long-term effects of COVID on children. And so those are NIH-funded initiatives that we are delighted to be participating in and helping with. And hopefully that larger group, because we didn't have that many patients, and so all of us getting together to pool our data will be incredibly powerful to understand the long-term effects of COVID.
Great. And I'll just add to that, I heard Mike Osterholm, who's an epidemiologist, quite expert on these things from the University of Minnesota, note that we're going to be studying things about this novel coronavirus probably for decades. You know, people are still studying the flu from 1918. So while it's completely understandable that everybody wants clear answers now, some things we're going to only find out over time, and it's going to take pulling together data and passage of time to get at some of the things that we'd like to know. But I think the key is that we make the start and continue to try. So Dusan, let me come back to you. So what do we do if testing for children, if a parent has tested positive? What do we understand about, is it necessary, is it not necessary? Do you have thoughts about that?
Right. So actually, pretty commonly, my friends come to me and said, you know, I was positive for the test. This means that my partner and my children are positive too, right? And there is no need to test because it's obvious that everybody's going to get it. So far, we know that the chance of infecting somebody in your household, if you are infected, is actually only at 20%. And everybody is shocked at that. It's like, well, how is that possible? I said, well, if you think about it, if it was that easy to infect, in 3 weeks, the whole globe would have been infected, right? So this one is a very infectious virus, but 20% in the same household. I can tell you in my household, I'm positive for SARS-CoV-2 antibodies, and my partner isn't. So this is a very common thing. So if you had it, it doesn't mean that your partner or your children have had it. What we have decided in my household to do is to test my partner, and we didn't want to bleed our children, so I don't know if my children had it, my partner didn't. So that was our decision, and it has to be, you know, family decision in terms of if it was a completely non-invasive test, or when we take them for a 1-year follow-up, we'll do this test as well as they're doing any other regular blood test for them. Because they're doing well, there is no reason to do it. So that was our decision. So it need not mean that somebody you live with, if you're infected, that they are as well.
And Dusan, to ask a follow-up question, unrelated, there's been a lot in the press, you know, about antibody titers, the amount you can measure in the blood dropping some months later, and maybe that means somebody can get infected again with the same virus. Could you just talk about how much we should be worried about, you know, you've had it once and now you're going to get it again?
Right. So it's very normal that how the immune system works is when we get infected with this virus or any other virus for that matter, the antibody titers skyrocket, right? So it's very normal for those antibody titers to go down. So that's a normal process of the immune system. It doesn't mean you're less protected at all, because you have educated your immune system and it can come back at a moment's notice. So the antibody titers falling down is a normal process of any immune response, including to SARS-CoV-2, and it doesn't mean that you're less protected. And actual studies coming out, Sinai actually, and others, have shown that you are capable of neutralizing the virus even with these lower antibody titers after now 4 months after being infected.
Right. George, let me come to you. It's a question flew by, and I think it's a good one. Karen can help also if she wishes on this one. What are the current recommendations about vaccinating kids? Obviously, we don't have a vaccine right now for against the novel coronavirus, but how about all the other vaccines? What are the current recommendations and guidelines around that?
Well, when it comes to all other vaccines, we highly recommend that children continue to get their regular healthcare maintenance. They continue to get all their vaccines as scheduled, and the presence of this pandemic should not inhibit us from seeking healthcare. We encourage all parents to get healthcare as planned pre-COVID, and we encourage that our kids also get their immunizations and all the vaccines that have been established before. With regards to COVID, I don't know if that's your question also. With regards to COVID, we don't have a vaccine yet, but at the present time, having seen what we saw, I would strongly advocate that once there's a safe vaccine established for all, that we should all get vaccinated. I think it's a very important way to address this issue. We know vaccines have been in our lives and have protected us from very bad illnesses and very bad diseases. Vaccines have saved lives, and we will strongly recommend that when a safe vaccine comes to the market and approved by the authorities, that we encourage that patients get vaccinated, and we will get vaccinated too.
Thanks, George. Karen, for you, I saw a couple questions come by. You've talked about the importance of social interactions. One particular kind of social interaction is sports. And that can be sports at a distance sometimes, but a lot of it is a whole lot closer. What are your current thoughts about how to approach that if sports is available for kids in terms of participation?
Yeah, so that's a great question, and I think we're still trying to understand the risk of, of spreading it in a sports activity. So once again, it comes down to what is the infection rate in the community. If you have a higher, I think the question was about Atlanta, and I might be a little cautious in Georgia right now about anything that includes a lot of face-to-face, and in-person contact. If it's just doing drills, then I think the case with soccer, if they're doing drills, if they're not actually sort of interacting with each other and hitting each other, then it might be a little bit more safe to do that. Any place where you're going to have very close contact, so you see what the NBA has done. So they are completely separated into their own pod in Disney World, and they've actually done a very good job of containing coronavirus by being able to do that. But basketball is a pretty close sport; like you're touching each other pretty easily. So I think those sorts of sports, I think you would have to be very, very careful about. There would have to be testing, and I don't even know that I would feel comfortable, advocating for a sport like that. Something like tennis, where you're separated by a net and 40 feet, like that's probably totally fine. So it is somewhat sport specific. My kids were fencers when they were younger, and they talk about that being the perfect sport because you're wearing a mask, and if somebody gets within 6 feet of you, you get to stick them with a sword. So it's but it's held indoors, so it's a little bit more problematic. So difficult decisions, but I think it depends on the community and the particular sport.
Great. And Dusan, George a moment ago talked about something we all think we're waiting for, and that's vaccines. I know Mount Sinai is actively involved in trying to develop vaccines. We're hearing about a number that are underway. We've heard about Russia deciding to go ahead and give vaccines now. What can you tell us, or tell us a bit about what we understand about where we're at and what's likely ahead in vaccine development, and when will we be able to safely get them, if you can say?
Right. So I think vaccines are well underway. There is a few leading ones that you have heard about. That is the Pfizer vaccine, that is the Moderna vaccine, and that is the Oxford, AstraZeneca vaccine. They are all going into phase 3 in terms of vaccine or any drug development. There is phase 1, phase 2, and phase 3. After phase 3, all the data has to come in, and then the decision is made whether that vaccine works. Phase 1, if it's safe. Phase 2 is if it's safe/efficacious, and phase 3, if it's actually efficacious, if it works. Because if it's safe, it doesn't work, why bother? So unlike what I understand has happened in Russia, this process takes time, and it has started here and worldwide with enormous speed. So I think we will have a vaccine. I don't think we'll have it in time for this school year to start. I'm assuming, and there is supply chains here, this is beyond just getting it approved. This has to be produced in millions of doses and administered. So I am optimistic about a vaccine and towards the beginning of next summer. So that's where I think is being optimistic. If anything comes sooner, that's great. In terms of the vaccines that we have heard in the news in other countries that are being administered to essential healthcare workers or military, from what I understand, it is very unsafe. I hope it works, and I hope it's safe for the benefit of those individuals who got it. But I don't think that's how it should be done. We simply have to go through this process of safety, efficacy, and only then we need to and can approve these vaccines. And once that happens, I will get vaccinated myself, and I will vaccinate my children.
Dusan,
Hi.
last question for you before I do the lightning round, and that is, we've seen enormous variability, certainly in kids, you've talked to that, but in adults too. Why is one person so sick and another person not so much? Is it genetics? Is it how much virus they had? What are these differences?
Right, so I think the safest answer and the only right answer is we don't know at this point. If you think, I mean, that's like my life's mission, to figure out the divergence in clinical outcomes following viral infections or even inflammatory diseases, which is what I'm studying. If you just think about the regular flu season, you know, somebody gets flu as we know it, you're malaised for a week in and out, you know, and somebody just sniffles and there was nothing going on and somebody dies, right? So I think it's a constellation of things. So it could be genetics, it could be comorbidities, it could be the amount of virus that has come in at that very point in terms of how much infectious dose you got. And then when you do all these combinations, you get these diverse clinical outcomes. But it's hard to parse out, really.
Thanks. So last two words to our pediatricians on the panel. So first, George, then Karen. George, what do you think are the important takeaways for people, in terms of their kids and dealing with this ongoing pandemic?
Well, I think that for us here at Mount Sinai and what we've been through and what we've learned through here, I think people should know that we're ready to take care of this illness, and we have. We also partnered with our teams and learned a lot very quickly to understand the disease and also take care of patients. I think for parents, the most critical thing is that what brings about all of these MIS-C or the straight up COVID disease is getting exposed to the infection. And so getting exposed to the virus is the number one thing, the underlying thing that causes all these problems. And so the key things is keeping up with the regulations that we have, keep hands clean, masking, social distancing, and we encourage everyone also to get their regular healthcare maintenance. Our hospitals are safe. We've done things, we've put things in place to make sure that it is safe for us as hospital workers, and it is safe for our patients. And so we have everything ready and able to do it well and do it right by our patients. And we encourage our families to have the confidence that we're doing it right and we're ready to take care of the patients, and we'll continue to be very vigilant. Thanks.
Karen, to you.
Sure, thank you. I think that to recognize that the risks to children are low but not non-existent, and the overall impact of COVID goes well beyond the immediate consequences of the infection, and particularly for underserved communities of color. And I do want to reiterate what George just said, that it's really, really important to continue getting medical care for your children. One of the things that we're quite worried about is that we are going to be missing things like childhood cancers because people are worried about bringing their children in to see the doctor. And as George said, we have done many things to make this a safe place to be able to bring your children. We were giving vaccines out to our children throughout the COVID epidemic. That was the one thing that we continued to do, were the vaccine visits, because we believe that they are so important. So please don't skip those visits, and please encourage your families, and the other people in your lives to continue to see the pediatrician or your child's healthcare provider.
And I'll just quickly add to that physicians have gotten very adept at telemedicine. There are some things, obviously you can't give a vaccine at a distance, but there are a lot of things we can do. And most of your physicians are now getting comfortable with that. And so where it's appropriate, that's an option. We want to thank everybody for joining us today. We're going to be putting up a slide that, because we have depended, a lot of the research you've heard about has been dependent on the generosity of the community. We've had an outpouring for which we are really deeply grateful. And and we look forward to continuing to partner. If we have questions that we didn't get to, feel free to drop us a line. We obviously will capture what have been put into the Q&A and so on, and try and post answers. And then at some point you'll get an email about the entire webinar being posted as well. And feel free to watch again or pass it along to others if you found it useful. Thank you so much for joining us. Have a great day.